Usually when we talk about taking medication, there's this baseline expectation of just, well, simple precision.
Right. It feels very binary.
Yeah, exactly. You have a headache, you swallow a pill, the headache goes away. It's a straightforward transaction.
But stepping into the world of hormone replacement therapy, or HRT, it just completely shatters that illusion of simplicity.
It really does. Because we were looking at a medical landscape that is highly customized, deeply pharmacological, and just heavily reliant on your individual biology.
Which is why we're here today.
Welcome to today's deep dive. We are exploring the highly adaptable world of HRT, specifically focusing on the delivery methods.
Yeah, we are looking closely at the actual mechanics behind patches, gels, sprays, and oral tablets.
Right, and we're pulling from modern clinical guidelines here like the British Menopause Society and IC, alongside some really detailed pharmacological data from Frontiers and Winona to sort of map out this terrain for you.
Because the critical takeaway for you today is this. When it comes to HRT, the vehicle delivering the hormone into your body dictates the outcome just as much as the hormone itself.
Absolutely.
I mean, the delivery mechanism fundamentally alters the pharmacological journey. A hormone absorbed through the skin behaves radically differently and carries a completely different risk profile than that exact same hormone swallowed in a capsule.
Which is wild to think about.
It is. And understanding how to navigate this varied menu of options with a healthcare provider, well, it really requires understanding those distinct physical pathways.
Right, but before we can evaluate those specific vehicles, the pills, patches, and sprays, we really need to establish the destination.
Yes, the geography of it all.
Exactly. We have to map out where these hormones actually need to go to do their job. Okay, let's unpack this. The clinical framework divides HRT into two main geographic categories for the body: systemic HRT and local HRT.
And it really helps to think about it like heating a house.
Oh, I love this analogy.
Yeah, so systemic HRT is like the central heating system. It's designed to warm up the entire structure by circulating through the main bloodstream.
Right, because the goal there is to treat whole body symptoms.
Exactly. That includes vasomotor symptoms like hot flushes and night sweats, widespread mood changes, and even systemic preventative care.
Like mitigating bone density loss to stave off osteoporosis, right?
You got it. Systemic delivery requires the hormone to enter the venous circulation in high enough concentrations to actually reach receptors in the brain, the bones, and the cardiovascular system.
Right. But then you have local HRT, which, keeping with that house analogy, it basically functions like a space heater placed in just one drafty room.
That's a perfect way to look at it. Local delivery is employed specifically for genitourinary syndrome of the menopause, or GSM.
And this condition encompasses the localized dryness, irritation, and painful intercourse that results from estrogen deprivation right in the pelvic region.
Yeah. And the treatment involves microdoses of vaginal estrogens, typically delivered via creams, pessary tablets like Vagifem, or even silastic rings.
So the functional difference there is really the absorption barrier, right? Local delivery is designed to just stay in that one room.
Yes, completely. The microdose of estrogen rehabilitates the local vaginal tissue, but the absorption into the wider systemic bloodstream is negligible.
It's just highly contained.
Right. The dosage is so intentionally low that it really merely saturates the local mucosal receptors. It doesn't create the necessary concentration gradient to push the hormone deep into the systemic circulation.
Which is a huge benefit for the patient.
Oh, massive. Because of this localized containment, a patient can use vaginal estrogen continuously over the long term without needing a secondary hormone to protect the rest of her body.
Like protecting the uterine lining from unopposed estrogen.
Exactly. It is a highly contained, targeted therapy.
And the prevalence of these symptoms really highlights why understanding both systems is so crucial for patients, I think.
If we connect this to the bigger picture, epidemiological data indicates that up to 80% of postmenopausal women experience those systemic vasomotor symptoms requiring central heating.
80%? That's huge.
It is. And simultaneously, roughly 50% of women develop localized urogenital symptoms that require the space heater.
So they aren't mutually exclusive conditions at all?
Not at all. A patient very often requires both delivery methods at the exact same time.
I mean, they might rely on a transdermal patch to elevate their systemic blood levels and stop the night sweats, while concurrently using a localized vaginal cream to treat dyspareunia.
Right, because they serve entirely distinct geographical needs.
Which opens up the most complex logistical question of this whole process, I feel like. We know systemic HRT needs to reach the whole house, But how do we actually get it into the bloodstream?
Right, the route matters.
This is the great divide in modern HRT delivery: swallowing an oral pill versus absorbing the hormone transdermally through the skin.
And the physiological journey of an oral pill is incredibly demanding on the body. Let's trace the path of oral estrogen, like an Alest or Premarin tablet.
Okay.
Swallowing that pill doesn't mean it drops straight into the circulatory system. It travels through the digestive tract, gets absorbed through the intestinal wall, and is immediately routed via the portal vein directly to the liver for screening.
Right. This involves the hepatic first-pass metabolism. The liver essentially acts as a chemical bouncer here.
Yes, that's exactly it.
It intercepts this massive influx of estrogen before it can even reach the rest of the body.
Because the liver's primary biological mandate is detoxification and regulation, it views this sudden, concentrated oral dose of estrogen as something that must be aggressively broken down.
It's like an intruder.
Pretty much. And the resulting bioavailability is remarkably poor. I mean, less than 2 to 10% of the oral estradiol actually survives this hepatic first pass to make it into the systemic circulation.
Wow, so the rest is just dismantled.
Completely dismantled.
And it isn't just a matter of losing cargo, right? The liver actively changes the chemical structure of the hormone.
Yes, it does.
It converts a vast amount of that active estradiol into estrone, which is a much weaker estrogen metabolite.
Right. And this creates a highly inverted estrone to estradiol ratio in the blood, which just doesn't reflect the natural physiological state of a premenopausal woman.
That makes total sense.
But beyond the altered hormone ratio, the most critical factor is how the liver tissue itself reacts to doing all this heavy lifting.
The strain it's under.
Exactly. Processing that much oral estrogen stimulates the liver to upregulate its protein synthesis. It starts manufacturing and releasing clotting factors, specifically proteins like prothrombin.
Oh, wow. So this biological reaction directly correlates to an increased risk of venous thromboembolism, like blood clots and stroke.
Yes. It also elevates C-reactive protein, which is a key systemic inflammation marker.
And one of the most surprising mechanisms here is how this liver upregulation impacts other hormones entirely, specifically through SHBG, or sex hormone binding globulin.
Right. The liver increases its production of SHBG in response to oral estrogen. And SHBG is a carrier protein that binds to sex hormones in the blood,
Effectively locking them up so they can't interact with cellular receptors.
Exactly. And because SHBG has a very high affinity for testosterone, this newly manufactured fleet of proteins basically goes out and binds up the patient's free testosterone.
So even if her total testosterone production is completely normal, it gets trapped.
It becomes biologically unavailable, which can severely blunt libido and just drain energy levels.
Jeez. So oral HRT sounds a bit like taking a bumpy, toll-heavy dirt road through the liver.
That's a great analogy.
You lose most of your cargo to the tolls, your vehicle gets totally battered, and you trigger all these systemic traffic jams like clotting risks and trapped testosterone.
Yeah, that's exactly what happens.
Whereas transdermal estrogen, the patches, gels, and strays, seems to offer a completely different route. By absorbing directly through the skin, the hormone enters the systemic venous circulation immediately.
It's the VIP express lane straight into the bloodstream.
Right. And bypassing that hepatic first pass completely rewrites the safety profile of the treatment.
It really does. Because transdermal estrogen doesn't flood the portal vein, the liver isn't forced to upregulate protein synthesis.
So no excess clotting factors.
Exactly. Consequently, transdermal delivery does not raise a woman's VTE or blood clot risk above her bottom line. It maintains stable inflammatory markers.
And it doesn't spike SHBG, so it protects her available free testosterone.
Right. And it preserves a much more physiological estradiol to estrone ratio, usually around 1:1 or 2:1, because the hormone isn't being aggressively metabolized before it can even start circulating.
So this makes me wonder, if the liver destroys so much of the oral pill, raises the risk of blood clots, and binds up free testosterone, why do we even use oral HRT at all? Why is it still on the menu?
Well, oral medications offer deep familiarity and ease of compliance.
True. People are just used to taking a pill.
Right. Swallowing a single pill every morning is a highly ingrained habit for many people. Plus, there are no adhesives to cause contact dermatitis, no gels that require drying time before getting dressed.
Okay, convenience.
Yeah. And furthermore, for a very specific subset of healthy, younger menopausal women, the way the liver processes oral estrogen can actually yield a favorable increase in HDL, the quote-unquote good cholesterol.
Ah, okay. That's a point for the pill.
It is, but clinical guidelines are exceptionally strict on the limitations.
Right.
For women with a BMI over 30, those with a history of migraines with aura, or anyone with an elevated baseline risk for cardiovascular events or blood clots, the British Menopause Society and NICE guidelines strongly direct physicians toward transdermal estrogen as the safest first-line route.
Okay, so since transdermal delivery is the heavily favored route for safety, it's worth exploring how that toolkit actually functions in daily life. Here's where it gets really interesting.
Oh, it really is fascinating.
Because transdermal HRT is not a monolith, right? It is incredibly customizable. The first major option is the transdermal patch.
Right, patches like Everel or Estradot, they utilize what we call zero-order kinetics.
Meaning a constant release.
Exactly. You apply them to the skin below the waist, changing them once or twice a week. They deliver a steady, continuous infusion of estradiol directly through the stratum corneum and into the capillary bed.
So this constant release rate entirely eliminates those sharp peaks and sudden dips in blood serum levels that inevitably follow swallowing a daily pill.
Right, it gives you that baseline stability.
But if a patient wants that steady systemic stability, but has a physical reaction to the acrylic adhesives used in the patches, they have to pivot.
Yeah, skin irritation is definitely a drawback for some.
And that brings us to transdermal gels like Oestrogel or Sandrina. The dosing mechanism here is fascinating to me. Patients literally use pump equivalents to titrate their medication.
Right. 2 pumps might be a standard starting dose, but a physician can easily instruct a patient to dial up to 3 or 4 pumps based on their symptom relief.
You can literally adjust the dose incrementally with the pump, rather than trying to accurately quarter a tiny oral tablet.
Which is so much easier. And the gels utilize an alcohol-based solvent.
Okay.
When applied to the inner arm or inner thigh, the alcohol rapidly evaporates. This evaporation process actively drives the estradiol molecules into the stratum corneum, the outermost layer of the skin, creating a temporary micro-reservoir.
Oh, a skin reservoir.
Yeah. The hormone then slowly diffuses from that reservoir down into the bloodstream over the course of 24 hours.
And the newest iteration of this solvent-based delivery is the transdermal spray, like Lenzetto. The user applies a measured mist, usually 1 to 3 sprays, directly onto the inner forearm.
And the transdermal transfer happens almost instantaneously as the solvent flashes off the skin.
But a crucial variable with all these topical applications is that the human body isn't uniform. The absorption rates vary wildly from one patient to the next.
What's fascinating here is how much transdermal efficiency relies on individual dermal architecture.
Wait, dermal architecture?
Yeah, the literal makeup of your skin, the thickness of a patient's subcutaneous fat layer, their skin hydration, and the density of the peripheral capillary beds in the application area, all of that dictates how much hormone actually makes it into the blood.
So one patient might process 2 pumps of gel perfectly, achieving optimal symptom control?
Exactly. And another patient might apply 4 pumps of the exact same gel and see 0 improvement in their hot flushes because their skin barrier simply isn't permitting efficient transfer.
Wow. So that second patient would likely need to switch vehicles entirely, moving from a gel to a patch just to achieve therapeutic blood levels.
Right, because doctors really have to monitor symptom relief and sometimes serum levels to ensure the chosen method is actually working for that specific patient.
And this individual variability is also why clinical guidelines issue such stern warnings regarding compounded bioidentical transdermal creams from unregulated pharmacies, right?
Oh, absolutely. Regulated pharmaceutical gels and sprays undergo rigorous kinetic testing to ensure their molecular suspension actually breaches the human skin barrier.
But compounded creams are mixed locally by pharmacists.
Right. And while the hormones inside might be biologically identical, the suspension creams themselves are highly unpredictable.
The carrier might just not work.
Exactly. The molecular size might be wrong, or the solvent might not effectively drive the hormone through the stratum corneum. A patient might apply these expensive compounded creams daily, completely unaware that almost none of the active hormone is actually reaching her bloodstream.
That is so frustrating. But solving the estrogen delivery puzzle, finding the exact patch, gel, or spray that works for your unique skin architecture is really only half the battle for many women.
Yes, because of the uterus.
Exactly. If a patient still has her uterus, introducing systemic estrogen on its own is dangerous. It rapidly thickens the endometrial lining and greatly increases the risk of endometrial cancer.
So the body requires a second hormone, progestogen, to act as a bodyguard for the uterus.
Right. So how is that delivered? Delivering that protective progestogen is just as nuanced, isn't it?
It really is. It must be administered either cyclically, usually for 12 to 14 days a month, to mimic the luteal phase for perimenopausal women, or continuously every day for postmenopausal women to keep the uterine lining thin and stable.
For patients who want simplicity, pharmaceutical companies do combine these agents. Like a product like the Everol Conti patch physically embeds both the transdermal estrogen and the synthetic progestogen into a single adhesive matrix.
One neat package.
Right. But for patients who prefer the customizable nature of estrogen gels or sprays, the bodyguard has to be delivered separately.
And the modern gold standard for this separate delivery is oral micronized progesterone, commonly known by the brand name Utregestin.
Okay, Utrogestin.
Yeah, Utregestin is body identical, meaning its molecular structure perfectly mirrors the progesterone naturally produced by the human corpus luteum. And it comes as a 100 milligram oral capsule. It is heavily prioritized over older synthetic progestogens, often called progestins, because extensive data shows it carries a significantly lower associated risk for breast cancer and VTE.
And it also avoids many of the adverse PMS-like side effects, such as severe bloating and mood instability that were really common with the older synthetic formulations.
Exactly.
But this introduces a glaring contradiction, doesn't it? I mean, we just detailed exactly why oral estrogen is so taxing on the liver and triggers such dangerous clotting cascades. Why is an oral route suddenly the gold standard for progesterone?
It's a great question. The hepatic first-pass metabolism issue is highly specific to the molecular structure of estrogen.
Oh, I see.
Yeah. When oral micronized progesterone passes through the liver, it does not induce that same dangerous upregulation of protein synthesis. It doesn't trigger the clotting factors, and it doesn't spike SHBG.
Okay.
However, the liver does metabolize the oral progesterone into various neurosteroids, specifically allopregnanolone.
And what does that do?
Well, this metabolite crosses the blood-brain barrier and binds to GABA receptors in the brain, which acts as a powerful central nervous system depressant.
Which explained why oral micronized progesterone is almost universally prescribed to be taken right before bed.
Yes. It leverages that somnolence, that drowsiness, to actually improve sleep architecture for menopausal women.
But if the oral route causes intolerable systemic mood changes or, next day grogginess, specialists utilize highly localized alternatives.
They do. And the most targeted approach is the intrauterine system, or IUS, widely known as the Mirena coil.
Okay, so this is like the space heater again.
Yes, the IUS is a prime example of isolating a drug to its exact site of action. It's a small T-shaped device inserted by a physician directly into the uterine cavity.
And once placed, it just continuously secretes a low dose of a progestogen called levonorgestrel straight into the endometrial tissue.
Right. The bodyguard is stationed inside the exact room it needs to protect.
I love that.
It creates a highly concentrated local effect, thinning the uterine lining and providing supreme endometrial protection for up to 5 years.
And it doubles as contraception.
Exactly. Because the hormone is diffusing directly into the local tissue, only minute fractional amounts ever escape into the systemic bloodstream. Patients get the vital uterine protection while largely bypassing the systemic mood side effects and breast tenderness associated with circulating progestogens.
And as a secondary benefit, the localized effect often completely halts the erratic, heavy perimenopausal bleeding many women suffer from.
It's incredibly clever.
It really is. And for patients who cannot tolerate the systemic effects of the oral Utrogestin capsules, but absolutely do not want a uterine device inserted, there's an off-label workaround that essentially combines the two concepts.
Yeah, this one is interesting.
Specialists will frequently instruct patients to take those exact same oral micronized progesterone capsules and insert them vaginally.
Right. It bypasses the liver and the digestive tract entirely.
Delivering the hormone much closer to the uterus to minimize the systemic drowsiness and mood impacts. So what does this all mean?
Well, it means a patient's regimen can be entirely bespoke.
Right. You could essentially mix and match your delivery methods. You could have an estrogen spray on your forearm, dialing in your exact systemic dose, while relying on an IUS in your uterus to quietly protect your endometrium without dampening your mood.
Exactly. It represents the pinnacle of targeted therapy. By decoupling the hormones and isolating their delivery methods, patients can maximize the therapeutic benefits of estrogen while heavily minimizing the collateral side effects of the progestogen.
Right. So estrogen and progesterone form the foundational pillars of this therapy. They handle the systemic, vasomotor symptoms, and the endometrial protection. But clinical protocols also outline 2 highly specialized delivery methods for addressing stubborn, lingering symptoms that the main pillars can't quite resolve.
And the first one is testosterone.
Right. Testosterone replacement is increasingly recognized as a vital intervention for women suffering from hypoactive sexual desire disorder, or HSDD.
Yes. This is characterized by a profound, distressing loss of libido, sexual responsiveness, and general energy that persists even after estrogen and progesterone levels have been fully optimized.
So the pharmacology makes sense, but the actual real-world delivery method feels incredibly improvised. Wait, so women are essentially just hacking male testosterone products and rationing them out?
This raises an important question regarding pharmaceutical infrastructure. There is a glaring lack of regulated female-specific testosterone products approved and manufactured globally.
Which is wild.
It is. Because the clinical need is so severe, specialists are left with no choice but to rely on off-label prescribing of male products, such as 1% Testogel, which comes in large tubes or sachets formulated for male physiology.
Right, and a standard male dose might be 50 milligrams of testosterone a day to achieve their physiological baseline. But a woman's physiological baseline requires roughly 5 milligrams a day, a fraction of that amount.
So to achieve this, doctors are instructing women to extract just a pea-sized amount of the male gel, or to carefully utilize one single pump of a canister every other day.
It is a fundamentally imprecise delivery method for a hormone that requires strict boundaries.
Absolutely. Because transdermal absorption is so variable, and because the dosing instructions are so improvised, the British Menopause Society emphasizes that this specific treatment must be accompanied by rigorous serum blood monitoring.
Right, to keep things in check.
Physicians must draw blood regularly to ensure the patient's testosterone levels remain strictly within the female physiological range. If the transdermal absorption is too high and the levels drift out of bounds, the patient risks irreversible androgenic side effects like voice deepening or clitoromegaly.
Okay, so that monitoring is critical.
Very critical.
The final specialized delivery method shifts focus away from systemic issues entirely and looks back at localized vaginal health. Vaginal prasterone, sold under the brand name Intrarosa, operates on a completely different biochemical premise.
Yes, Intrarosa is a daily vaginal ovule, a small suppository utilized to treat severe dyspareunia and vulvovaginal atrophy when traditional local estrogen isn't enough or isn't preferred.
The key distinction is that Intrarosa doesn't contain active estrogen. It contains 6.5 milligrams of dehydroepiandrosterone, or DHEA.
Right, and DHEA acts as a prohormone. It is biologically inactive on its own. It serves purely as the raw material.
Okay.
The pharmacology relies entirely on a concept called interchronology. When the DHEA ovule is placed into the vagina, the localized cells take up that raw material.
And then they do the work.
Exactly. Because those specific cells contain the necessary intracellular enzymes like aromatase, they actively synthesize the DHEA, converting it into active estradiol and intracellular testosterone right there inside the tissue.
Wow, the cells themselves are performing the complex manufacturing on-site, converting the raw material only into exactly what they need to repair the atrophied tissue.
And because this entire conversion process happens intracellularly, the active hormones are utilized and then degraded right there in the local tissue.
Oh, I see.
There is virtually no active estrogen or testosterone spilling back out into the systemic venous circulation.
That's amazing.
It is. This localized intracrine mechanism allows a patient to aggressively treat severe vaginal atrophy without ever requiring a concomitant progestogen to guard her uterus, because the systemic levels remain completely unchanged.
It just leverages the body's own localized cellular machinery to create the exact localized cure.
Exactly.
We have covered a massive amount of pharmacological ground today. Bringing it all back home, the central takeaway for you is that HRT is not a single monolithic drug. It is a highly customizable, multifaceted toolkit.
Yeah, the decision between a pill, a patch, a gel, a spray, or an intrauterine system isn't arbitrary.
It depends entirely on the unique biological architecture of the patient. It depends on the metabolic function of your liver, the hydration and thickness of your stratum corneum, whether your uterus is intact, and your baseline cardiovascular risks.
And the objective of mapping out these intricate pathways is empowerment. Armed with this knowledge, a patient can walk into a clinic and engage in highly precise conversations.
Yes, the dialogue shifts from merely requesting hormones for menopause, to actively discussing the pharmacokinetic vehicles delivering those hormones.
Understanding how a transdermal spray bypasses the portal vein or how an IUS localizes endometrial protection allows a patient to truly collaborate with their physician to build a regimen that maximizes relief and deeply minimizes systemic risk.
I want to leave you with a final provocative thought to mull over. We've just spent this entire deep dive exploring the profound advantages of transdermal delivery. We've seen how effectively the skin can act as a VIP express lane directly to the bloodstream, completely bypassing the liver, maintaining stable inflammation markers, and dramatically lowering clotting risks compared to oral alternatives.
It's a huge advantage.
So consider the sheer volume of daily oral medication society relies on. Millions of people swallow daily statins for cholesterol management, daily SSRIs for depression, or daily antihypertensives for blood pressure.
Right.
Every single one of those pills is taking that toll-heavy dirt road through the digestive tract and the liver, often triggering a cascade of systemic side effects and metabolic strain along the way. If the Menopause Toolkit has so conclusively proven the safety and efficacy of transdermal administration, what other daily pills in our medical cabinets might eventually be revolutionized or completely replaced by a simple, continuous-release skin patch?
That is a great question.
Something to think about. Until next time.